Welcome to the Ortho on the Go podcast. My name is Chuck Dowell, host of the podcast. This is an educational orthopedic podcast focused on discussing both clinical and functional orthopedics. We will discuss a variety of topics within the field of orthopedics, including reviewing interesting cases, hearing from different professionals throughout the orthopedic profession, and discussing common musculoskeletal injuries and complaints. This podcast is meant for anyone that wants a better understanding of orthopedics, including all levels of practitioners, coaches, parents, and athletes themselves. Hello, everyone, and welcome back to the podcast. My name is Chuck Dowell. I'm one of the PAs and co-hosts of the podcast. Today, we're doing a case. So this was a 24-year-old gentleman who I saw in clinic. He complained of 1 day of increasing pain within his foot. He states he was attempting to step over a dog gate that was at the top of the stairs. He misstepped, landed on his foot in a bit of a plantar flex position. Immediately had pain, felt a popping sensation, was unable to weight bear. Ended up going to the emergency room where x-rays were taken. The x-rays were concerning for a ligamentous injury within the foot. He was then placed into a splint and told to remain on crutches, non-weight bearing, and a CT scan was ordered. He came in the following day to see me in the orthopedic urgent care for evaluation regarding this. So again, if you kind of take a minute, if you're listening to this case, if you're following along on YouTube, I do have the images up as part of the case, so you can kind of see the images that he did present with. But what's your immediate thoughts? He comes in, he is stepping over a gate in a slightly plantar flex position. He lands wrong and immediately has significant pain within the foot area. So on examination, he did have noticeable oedema diffusely throughout the midfoot area. He didn't have any significant ecchymosis noted. There was significant tenderness noted throughout the medial midfoot area, especially over the dorsal aspect of the midfoot, but some did extend into the plantar aspect of the midfoot and medial arch area. He had decreased active and passive range of motion due to the acute injury. He had increasing pain with kind of compression of his metatarsal heads, and supination pronation caused significant increasing midfoot pain. So again, with this kind of presentation and exam, what are your initial thoughts? So those of you that are following on YouTube, you can see that the initial x-rays, including kind of an AP and lateral of the foot, do show some concerns of widening within that first and second proximal metatarsal junction, and to show that there is loss of alignment between that medial side of that second metatarsal and that intermediate cuneiform. And typically this represents concerns for possible Lisfranc injury. The lateral view did show, if we zoom in here a little bit, that he did have that proximal aspect of that first metatarsal is slightly dorsally displaced, which sometimes can happen with that Lisfranc type injury as well. Again, secondary to this acute injury and his x-ray showing that there was widening of that area, the concern was this likely would not be able to be treated non-surgically or non-operatively, and he was referred to one of our foot and ankle surgeons. So when we're talking about Lisfranc injuries, these are frequent injuries. The Lisfranc is a ligament that attaches between the The Lisfranc is an interosseous ligament that goes from the medial cuneiform to the second or the base of the second metatarsal. So if we look at our normal anatomy here, you can see that medial cuneiform and that base of the second metatarsal. There's the dorsal aspect of that ligament. What a lot of us may get confused at is that oftentimes it's the plantar aspect of this ligament that is the true Lisfranc injury. And these patients often present with some plantar ecchymosis. So again, if you're following along on the YouTube channel, you can see the picture here shows there's ecchymotic changes within that medial arch area. The plantar ecchymosis can be fairly significant and indicative of a Lisfranc injury. So again, if somebody comes in with an acute injury to the midfoot or the foot area and they do show signs of this plantar ecchymosis, you could think possible rupture of their, medial arch or plantar fascia, but you could also think pathognomonic for possible Lisfranc injury. So again, the plantar aspect of that ligament is the most common one that's injured and typically what causes that plantar ecchymosis. That goes from that medial cuneiform to that second and third metatarsal proximal aspect. The Lisfranc is a critically stabilizing ligament between that first and second metatarsal joint. It does maintain the midfoot arch. It does typically tighten up within a pronation and abduction position. And you have to remember that is a complex of ligaments. So oftentimes when we see an injury just to that ligament, it's not just to that ligament, but oftentimes we'll have fractures or widening between the ligaments or the intermetatarsal ligaments of that second, third, fourth, and sometimes even that fourth and fifth. In our particular patient, it was hard to tell based upon the imaging, but it does look like he has a small fracture here at the proximal aspect of his third metatarsal and possibly even of his fourth metatarsal. So he ended up going to surgery. You can see here the operative photos or post-operative photos that were taken. They did put plate fixation in there to kind of recorrect that anatomy and also screw fixation because there was effect of that third metatarsal going to that lateral cuneiform. Post-operatively, oftentimes these are non-weight bearing. So this patient was placed in a splint initially for 2 weeks, came back and saw our orthopedic surgeon, and then the swelling had reduced at that point and was then transitioned to a cast. The cast will remain on for about 6 weeks. He's strict non-weight bearing when in the cast. After 6 weeks, to 8 weeks of non-weight bearing. They can then progress to weight bearing activities and a walking boot. If we're treating this non-operatively, typically we do immobilize these with a cast. The cast immobilization is usually for 8 weeks. You can consider, different options in different patients if they don't or have an ability to not be fully non-weight bearing. You can consider a cast boot and maybe a knee scooter for those patients. Typically, they do quite well, but the healing time is quite long for these. So you have to, discuss with patients that oftentimes the foot remains swollen for longer than most things because it's kind of at the bottom of the hill. And so oftentimes the swelling accumulates in that area. And because of that, and because it's a weight-bearing joint, it often takes longer to heal. So these can take 6 to 8 months, if not plus, for healing. This patient actually at 3 months was doing well. He had progressed to weight-bearing activities in the walking boot, was starting physical therapy at that time, and was progressing quite well. So again, if you have a patient that comes into clinic, these are quite impressive typically. Most of the time the patient will come in with a lot of edema throughout that midfoot area, fairly significant pain, difficulty or inability to weight bear within the area, and then again look for that pathognomonic changes with that medial plantar bruising that may occur. Again, I hope you enjoyed this case. Thanks for listening, and we'll talk to you on the next one.